Dr. Bonnie 360, and we're here today to really have a discussion with you guys about this topic, which was first called open versus closed data and what are the business models. But it's an interesting story to even hear how this topic has evolved. It began when I was doing research on big data and looking at cancer companies and also rare disease companies and thinking about sharing data and knowledge sharing networks, actually in conversation with Jonathan. And then, though, the news started happening of all these platforms coming into healthcare. We've got Apple, Google, Samsung, and others, and we've got news that Amazon's, meeting with the FDA. So the conversation has evolved from just thinking about data and data business models to platforms. And that's how we're going to kind of frame this for today. And right now, I'm going to introduce our panelists. Chris Hogg, and I'm going to tell little secrets about all of them.
Right.
So he's currently the COO of Propeller Health, but some of you may also remember him from Practice Fusion. He and I share an interest in people and math. And here's, can anyone guess, maybe Malika, what the secret's going to be? We have a secret career path that nobody knows. Can you guys guess?
For this guy?
Yeah. He's a ninja. Okay.
Now I'm interested.
The secret is Chris and I both worked on Wall Street. Very few people know that. And then next, let's see what we're going to, here you go. We have Jason. So why do I love Jason? Because in my first research foray in digital health, I got to look at mobile social games for health, all about digital health platforms, and think about play and having fun. And so every time I meet with Jason and look at that twinkle in his eye, which we can see right now, it reminds me of having fun and gaming platforms. Now, Jonathan. So Jonathan is actually the founder and president of Syapse. And I met him quite a while ago, before I knew what an omics platform actually did. So in other words, like many of us, I had to come up a very steep learning curve. But Jonathan not only has a big mind, but he has a big heart and soul because he was able, willing, and open to help me. And I bet that he's helped many other people come up similar and different steep learning curves. So we've got this great panelists who may or may not tell us more secrets about them. And originally, when we were thinking about kind of how to frame a business model for just a data-driven business, I did a lot of research and began to think how you might stratify or what would be the framework you could think about if you were just talking about a data-driven business model. And here are some key metrics. When you think about where does the data come from, is it an inside or outside, or what are you doing with the data once you get it? Are you processing, analyzing, distributing? And then who are your customers and the revenue models? So we began to think about how these three companies, who are all over the map, might look. And that's where we're going to begin our discussion. And then we're going to go to have each of them talk about what makes a platform and how they're using open versus closed data and which business models. But we're actually here to answer all your questions. So if you want to interrupt in between all of this, go ahead. We're going to start with Chris.
Great. So as Bonnie said, I'm currently at Propeller Health. Propeller is a digital therapeutic focused on asthma and COPD. So we have FDA-approved sensors that go on inhalers to instrument inhalers. And so we can collect data on regular patterns of medication use. So we have two main users. One is the patient or caregiver, and then the second is the care team, so care coordinators, physicians, and nurses. We are collecting data from the sensors. We're also bringing in data about the context of which a person is using their inhaler. So we can pull in information about the weather, pollen counts, location, and try to create correlations and patterns to help people understand their asthma attacks or their COPD exacerbations. We give the data back to physicians and care teams. We give the data back to the patients themselves. And we also, in certain cases, have given the data back to public health groups. We did a big project in Louisville that was sponsored by the Department of Health for Louisville, where we instrumented a bunch of asthmatics and then gave the data back to the city. And they then used that in policy making, so places where they might try to reduce admissions, change traffic patterns, et cetera. And I forgot what the last box was.
Last box.
So I think that's it. So yeah, so we share it back with the users, and then in certain cases we share it back with public health officials. The goal of the company when it was initially founded was really around public health, and if we could collect better data about where asthma activity occurred, it would be able to influence at a very high level public policy and improve patient self-management.
Hi everyone, I'm Jason Oberfest. I'm the founder and CEO of Mango Health. We're a mobile health company, and our focus is really building products that inspire mass market populations, patients and consumers, to really think differently about their health each day and start planning and better managing their health each day. Our focus initially is on medication management and adherence primarily, so very similar in a lot of ways to the work that Chris and his team are doing. We're slightly different, though, in that we're not focused on a particular condition, such as asthma. We support managing any combination of prescription medications, over-the-counter medications, and nutritional supplements for any health goal, fundamentally. So we do work in a similar way. We have a freely distributed, freely available app. We've been very fortunate. It's been promoted by Apple for about 16 months now straight. And we also work with many of the leaders across healthcare to help them improve the outcomes of their patient populations as well by using the app. So similar kind of model. We collect similar types of data and work in fairly similar ways, actually, I think.
Jonathan Hirsch, founder and president of Syapse. And what we do is probably a bit different than these guys. We provide a precision medicine data platform. And what that is software as a service that gets installed at a hospital and helps the physicians utilize data both from their medical record and many other sources within the hospital, but also the non-traditional data sources like the patient's genomic information to figure out how to treat the patient. So just to give you a concrete example, since this is a little bit outside the typical M-Health, D-Health field that you guys are probably used to. So if you walk over one building to the Stanford Cancer Institute right next door, what happens today is a patient comes in with late-stage breast cancer. The physician has a referral on that patient, which is basically a 50 to 100-page fax. So it's a fax that gets slapped on their desk. The physician orders a bunch of tests through the medical record. They put the patient on a bunch of drugs. And then they order genomic sequences and molecular tests. All of that information at the end of the day is unstructured textual data that might even be on a piece of paper sitting on their desk. The electronic medical record provides little to no value to the physician when they're trying to figure out how to treat the patient. So what we do is we go in and we clean up all of that data that the physician already has access to, and we give them a piece of software to understand the patient, to get a set of treatment options, to look at prior patients who may have been treated by that physician or at that medical center, and to use that information to select the appropriate treatment, monitor the patient over time, and figure out how to use that patient's information for the treatment of subsequent patients. So in terms of data that we deal with, we are actually going into the medical record and cleaning up all of the terrible information that exists in the medical records. We're digitizing what is currently on paper, and we are then enabling the sharing of information across healthcare entities. So if you're Stanford and you want to share information with UCSF or share information with the referring physician, we're doing that as well. One important thing to point out about our company that relates directly to this is that we as a company don't own the data in our platform. The data is owned by the patient. The data is owned by the healthcare provider entity. The data is owned by the physician. We as a company don't own data. And that is a specific business strategy that we chose to enable us to be platform and data agnostic and to really enable the data to be shared across organizations where appropriate, and not to have our business incentives mixed up with the medical incentives of the patients and physicians that we deal with.
And let me give you some more context of why this is so important and why thinking about data and platforms and business model really matters to each of you. So when you're a patient and you want personalized medicine, or you want to know what drug works for you, when, where, why, and how, all of this data eventually, in theory at least, should be able to come together to help make better decisions for each of us. And so that's kind of the broader picture of, despite the hype and the hope about big data, it really has potential, at least in theory, to get us there. But now we're going to backtrack to some of the practical parts and see how each of them thinks about platforms and what a platform means, and is a platform the beginning of helping us get to where we want to go as patients. Chris, you want to start with that?
Yeah, sure. I mean, I think the concept of platforms is very complex, so it's probably more relevant my old job. So up until about a month ago, I was the head of data science at Practice Fusion. And so we were data creators, we were also data aggregators, trying to bring in a bunch of information presented at the point of care in front of physicians. And it becomes a very complex a problem. You know, we had the data, we had rights to the data, it was a monetization strategy, but it was also for utility in the platform. And the question then becomes, so there's two questions. One is, you know, should we send it out and should we bring it in? And then the second question is, how do you do that and who pays for it? And so we were getting involved in a lot of complex agreements, you know, with accountable care organizations and people that wanted all of this data. And when you have a model, you know, it was a free electronic EMR. And so then the question is, so what happens? How does data come in and out? And are you charging for that? And the question of ownership is a big one. You know, Jonathan mentioned that they don't own data. I would argue that nobody knows who owns any data. It's not clear at all. It's basically, you know, we have information on our servers. What do we do?
Do we have a question back there?
Yeah, right now, I mean, it's very contractual. I mean, it's all written into terms of use of any platform or program or app that you're using, and it's never really been tested, any of these things. So you have a high variety of terms of service, terms of use agreements that basically don't ever explicitly talk about ownership. They just talk about rights, rights to de-identify, rights to use, rights to transmit, rights to sell, et cetera. And it's going to come to a head, I think, at some point, but it just has not.
Well, then come closer so we can hear you.
Yeah, I mean, if you look at all of the apps that are, or products that are data creators, you know, you're adding information in. It would be a fun and interesting exercise that I don't want to do, but to lay them all out and someone to analyze all the terms of service of these different things. And there's very high variability in the use agreements. And it's difficult to start thinking about platforms and generation of platforms when there's all of these big uncertainties about how the data is used. I mean, Apple is a great example. I mean, they're just being very explicit. If you suck data out of HealthKit, these are the rules. And I think maybe it takes somebody of that heft to start bringing in standards that other people will model and follow, just as the way that they're going to be setting standards of data classification and how we structure the data. Because right now it's just incredibly variable.
But the word platform has two meanings, actually. Some of us think of it as an IT term, and some of us think of it with a capital P as a business model. So let's hear from Jason which one he wants to talk about.
Yeah, so I was particularly excited to be involved in this panel because I've spent most of my career building platforms. This is my first run in healthcare platforms, so most of my background has really been in consumer technology, and I've launched and built the developer platform at MySpace, really in the earliest days of social networking. And then I did the same thing at my last company, which was really one of the first, and we became one of the largest iPhone and card game companies. So I've been spending a lot of time on platforms, and I think it's really important to kind of take a step back and really think about, as Bonnie was getting to, like what really defines a platform fundamentally. And the way I think about it is, first of all, what is a platform? And then secondly, what makes a platform successful? So I think what a platform fundamentally is a network that supports a bunch of different stakeholders. And the very principle behind it is that the end result of this platform is greater than the sum of any of the individuals can do on their own. And that's fundamentally, I think, what a platform is. What makes platforms typically work, not always, but typically work, is they need fundamentally three things. There's a guy named Dave McClure, who you guys may know. He taught the first Facebook app class here at Stanford, and he's an old friend of mine. We've worked on a lot of things. I remember he kind of was well known for saying, really, platforms have three things fundamentally: features, users, and money. And you can think about how that applies in the context of healthcare. Features may be either built software that others can take advantage of. It could be access to data that's valuable to different parts of the platform. But in any case, it's features, users. It has to be at scale generally to be really effective, whether you're talking about active users in the system or the scale of data in the system. You need scale for platforms to be generally really successful. And you need a way for everyone who's involved in the platform to derive value from it fundamentally. So in the old Facebook app days, it was all about, how much money we were getting per active user per month. Here it could be about, the ability to unlock real value in data, to improve clinical outcomes, the ability to reduce cost of care over time, whatever the objective may be. But you really need all three of those things, I believe, for any platform to be successful. So that's how I think about building a platform in healthcare today as well.
So our story is a little interesting. We actually didn't set out to build, what we would consider to be a platform. We set out to build a point application to solve a specific physician problem, access to the appropriate information to make a treatment decision for a cancer patient. But when we went into all these hospitals and clinics, there was no platform for us to plug into. You think that the medical record is a platform, it's not. There is no place that we could go to plug in and access the data, access the users, put our application in front of people. It just didn't exist. So we began getting dragged in, and I use that word intentionally, but dragged in to the platform business, where we actually will go into a hospital, we'll go into a clinic, and we'll become a platform of theirs. We'll become their quote-unquote precision medicine platform, or we'll become the data platform that has all their cancer patients in it. And once you, to your point and to Dave's point, once you actually get in and start down this road, you actually get users coming to you. So we'll get biopharma companies, we'll get other software and analytics companies approaching us because the data that they want access to is actually in our platform. And by going in and solving this one specific physician problem, we actually got into the platform business. And to your question before, the whole concept of data ownership is, on the one hand, very confusing, and on the other hand, for us, very straightforward, which is we don't want to be entangled in the data ownership issues. So we state very clearly in every single one of our contracts, which are actually publicly accessible online, that we don't own any data. We don't have right or title or license to it, but it very clearly says we don't own the data. And when you actually go into these hospitals and ask them, do you own your patient's data, you don't get a good answer. So why would we as a company, when we're working with hospitals and complex legal entities, why would we want to get into this data ownership quagmire?
So you can see how they have very different views of platforms and how they're using it in their own business models. And I think another interesting question I'm going to pose is, not only do we have Apple, Google, Samsung, and others, all coming into healthcare at the same time, but we have these unusual, or I'll just call them new collaborations, such as Salesforce and Philips, who are looking more at the chronic disease management market. And then we have IBM Watson, which has opened its platform and done an agreement with WellTalk to help consumers with their wellness. So I think the real interesting question, if you sit back and I'm going to hear their views, is why do we have all this activity right now, and who wants to think about what it means for the future of the next question, which is, will most or some of the data be open or closed, and what might those systems look like? Who wants to tackle this tough one first?
I'll jump in. I mean, I hope the reason is because finally the incentives are turning around in the healthcare system in our country to really warrant focus here. And people are really, centered around this idea of empowering patients to make good decisions, focusing on long-term health improvement over time. Let's hope that's what the answer is, because that's certainly, I think, what the industry needs. I have a general point of view. I think those who run platforms for business reasons, and I'll just kind of throw an idea out, and I'm curious, what everyone thinks of this. What I've seen over my career with platforms is that platforms are generally, and this is a bit of a skeptical point of view, I guess, but I think it's an important concept to consider, is that platforms generally are only as open as they need to be to drive their business forward. And the more leverage they get in the market, the more of a leadership position they get in the market, the more closed they then become. And I think I've seen that mistake made in a lot of other industries with platforms, and what I'm really hoping is that that's not the case in the healthcare industry, as platforms really do open up for the first time in a meaningful way. So I don't know if anyone else agrees with that. Or
I definitely agree with that. And I think the other mistake that a lot of people try to make is they try to create a platform. You don't actually ever from nothing create a platform. You create a product, and the product does so well that other people want to leverage it, and it becomes a platform. So I'm very skeptical of all of these companies that are just trying to become the meta layer platform where I'm going to organize all of the apps and all of the disease management programs and then sell them into employers or sell them into systems, because what you're trying to do is create a double-sided network simultaneously while providing value to neither side. And I've never seen that work. Maybe somebody gets lucky and does that. So I actually think a lot of these people that are just jumping in, obviously it's a $3 trillion market, we're already a platform, and we can create a platform in healthcare, we're gonna make a lot of money, but there's no value proposition really to anybody. And I don't care how big the company is, I'm pretty skeptical of a lot of these folks jumping in right now until they have a really clear value prop need that they're providing to one side of that network, so that they start building some kind of momentum on one side, and that brings in the other folks.
Well, part of the reason could be because of the size of the platforms, their incremental cost to jump into healthcare is relatively low.
That's fair, but they're still providing no value to anybody.
Okay, good.
I mean,
Question.
Oh, no, I was going to say, you mentioned several platforms that supposedly directly impact what we do. The only time I see IBM Watson in the healthcare industry is when I'm getting on a plane and I'm in the airport and I see a Watson ad. Watson is just not a factor in the actual work of cancer care, in spite of what their advertisements might say. So they're not delivering value, and none of these guys are delivering value to anyone yet. So when we see them get a customer, then we can talk about it.
The ones I would like to see develop into platforms are the ones who are older, more traditional, but already entrenched, like an Optum, where we deal with care coordinators all the time, and they're using an Optum care coordination software, but I can't integrate with it. So I'm creating a sidecar experience that's creating tasks for care managers that then they have to log into, or I have to figure out how to do it. But these ones, they might not be awesome products, but they're effective, and people are using them, and they know how to get them into systems. And so that's much more valuable. We already have a lot of care managers or practice nurses using this product, and now you have an extra benefit, so plug into it. But I haven't seen that happen yet.
But Optum is completely closed, or is it
That's
open?
what I mean.
Yeah. Okay.
But it would be great if they had an API where I could create tasks into their task management system.
Or think about Epic. Epic could flip the switch tomorrow and be a platform and, kick all the other guys to the curb. For whatever reason, technical business strategy, they haven't done it. But they're already in providing value. They've got, whatever it is, 50% of patients in the U.S. in their system. They could flip the switch and become a platform.
Yet it's not their business model. Listen, you hear the two interviews that Judy has given by the company. Her customer, really not the physician, it's the institution. You see XOs who write a check for $200, $500 million.
You're underestimating.
She's got her customer without having to need to expose a platform.
I'm also, having dealt with them now for the past few years, I'm also convinced that part of the reason is technical as well. That it is not a simple technical feat for them to create a platform. It would be significant investment, and why bother with all the government incentives today? You can.
COBOL's not easy to integrate.
But let's hope, though, right? Let's hope that the true Epic customer, that over time their incentives are going to change, right? They're going to be measured in different ways. They're running organizations that need to think and do differently. And I really fundamentally believe, I think exactly what Chris is saying, that any of us working in innovation in any part of this space, for the most part, and there will be a few exceptions to this, they need to work what they do back into the way the entire system is used to working. So we can create huge lift in patient engagement and medication adherence, things like that. But if we can't quantify that and deliver that back into a system that everyone that we work with uses every day, we're not going to be successful. And that comes with working with Epic or Practice Fusion or Athena Health or Optum or any of these other systems. I think we have to continue to push on those folks to really think about this, because ultimately I think they'll be measured, hopefully, in that way.
It's got to be in the workflow of the physician who's just sitting in front of an Epic screen.
Right.
15 other
Exactly right.
portals.
Or the care coordinator, or whoever.
Yeah.
And so I think what's going to happen, and we can see this problem coming. I mean, there's already a bunch of verticalized population management solutions, and we're one of them, right? We're just focused on respiratory, and you have Amada focused on prediabetes, and you're going to have X, Y, and Z focused on all these other ones. And so it's not a problem today, but eventually, then all of a sudden, these care managers are going to have 13 sidecar programs, and it's not going to work. And so you already see a lot of people trying to create the meta layer above it that's going to organize all of them. But I actually think that if the people who are already integrated, like Optum, in these don't do this, then one of these companies is going to create such a nice solution for these care managers that then they're going to be the ones that integrate the other ones. And so that's the way we see it going. But it's going to come out of product. They're going to create a delightful, awesome product experience that then the users want to be leveraged across diabetes and respiratory and whatever else. It's business model. It's also super technical. I mean, this is really hard. You could say, I'm going to be an open platform. I'm going to integrate every blood pressure device out there. This is not an easy problem. I mean, the data that comes out of these things is like ridiculous. And so then you start to see the Valytics and the people that are trying to create like normalization layers, and now Apple's going to try to be that normalization layer. Maybe that jumpstarts the problem. But it is both like business model, but okay, I have to believe this future benefit, and I have to expend a tremendous amount of costs and resources to actually do it. So I don't believe in like the flip the switch concept. Epic cannot flip a switch and become a platform.
Many of the problems actually lie within the hospitals themselves. So just to give you one absurd example that came up last week. So we were doing a large Epic integration at a local large medical center, and the bill that someone is supposed to pay to get us 20 fields of clinical data from Epic pushed to us every single day is $17,000. Now, why is that the case? Why don't the hospitals understand that once they've put this Epic system or Cerner system in place, that they also need to be able to leverage and utilize the information that's stuck within the system? So that's just one absurd example, and I can give you, 50,000 others, but it's not Epic's problem. This is, at the end of the day, the hospital's problem. The hospital has put up a set of barriers to adopt innovations like ours, and the hospitals need to figure out if they're going to embrace the technology that we're developing, if they're going to listen to their physicians who want this technology, or if they're just going to be afraid. and they're going to say everything must be within Epic, and that's it.
Yes.
What do you think? So,
Yeah, I think, I mean, the key that we found is, seems like a kind of very general answer, but I mean, this is true for so many hard problems, is number one, the incentives have to be there. So if any of our programs are producing evidence that we really do improve outcomes and lower costs of care, which certainly our program is, I'd imagine Chris's program is too, and others are, the incentives are there. And then it's just a question of structuring it in a very iterative, bite-sized sort of way. So part of the problem, I think it's very easy to get wrapped up in these very, very complex issues that are just nearly impossible to solve in any short amount of time. So what we spend a lot of time doing is working with our different partners, and we're fortunate because we work with many of the leaders across most of the parts of the healthcare system right now, to really kind of parse out, like, what's the first thing we can do here relatively easily to demonstrate value for you and for the system overall, and build that case and then kind of iterate from there. And that's how we've been able to make progress, just breaking everything into these very small bite-sized goals.
But to talk to us about, all of you, the nitty-gritty of the business models, either your own or some others that we see evolving, you know, who's getting paid, who's not getting paid, what's going on?
I think it's actually becoming much easier to get paid if you're focusing on costs and outcomes that what people are used to paying for. Now we just don't have to go through a whole process of getting a reimbursement code. We can just go in and have a really easy, relatively easy conversation talking about engagement, users, you know, patient satisfaction and costs of something that's very expensive.
Who pays for Propeller?
Oh, so payers, ACOs, like at-risk systems, anyone who's taking risk.
And is it by member, by outcome? What's the
So
criteria?
there's a shift going on. So we're getting paid by member, so it's a PM, so there's upfront cost and a PM per member per month fee. But then you have folks like, there's another panel actually after this one, but folks like Omada who are starting to go at risk, and that will be the model. So once these companies like ours can become quite predictable in the implementation and the execution, then it becomes an easy proposition to start sharing risk with these risk-taking entities. And I think that's the way things will go.
Yeah, we do something very similar. So we actually run a hybrid model where we do flat rates to initially kind of get up and running. And that flat rate is entirely dependent on how sophisticated. To that point about iterative approaches, like, it was very important to us to have a very modular and flexible approach where some systems are very advanced, very far along, and want to do really innovative things, and they want to invest up front in pretty complex, sophisticated integrations. So we'll staff for that up front. And then others are much more interested in very light, fast ways to get going and start testing that we can get up and running in a matter of 3 to 4 weeks. So we'll do a kind of flat rate to cover whatever the scope of that initial type of work is, and then we do an at-risk model on top of that. And our clients are very similar. It's anyone who's at risk, anyone who has the right incentives to improve outcomes and reduce costs over time. That's who we work with.
So it sounds like what we're hearing in the beginning of these business models is flexibility is key, and delivering value first, and then pricing it flexibly. Is that sort of the theme? No?
I think I'd say aligning the incentives correctly is key, more than flexibility is key.
And having a really concrete bite-sized goal, I think.
Okay.
So having very, very focused, very clear, we're going after this patient and trying to do this thing, rather than we're trying to do everything for everybody, is a much harder sell. I've been in both cells.
And Jonathan doesn't agree.
No. It's not that I don't agree. It's just that we just have a different model. So, you know, we're very clear on a few things. So number one, our user is the oncologist. That's our user. Our user is actually not the patient. We don't touch patients directly at this point. And we have a very simple pricing model. We charge an annual subscription fee based on the number of oncologists at the entity. And the reason that we can do that is our software, we don't have a clinical program per se like these guys might. we are providing, utility software, infrastructure software. So what we can make an economic argument to the hospital is your physician has lost 50% productivity because of your medical record. We're going to help them gain back, 40% of that 50%. And here is concretely how we're going to do that. And yes, clinical outcomes do improve, but it's actually an efficiency argument directly to the hospital. And because of that, it's actually relatively easy for us to go in and say, the cost to you is going to be, X hundreds of thousands of dollars, and you're going to make that up within the first 6 months of the engagement.
Yes. Yes. Hold on.
Thanks very much. I'm intrigued by your experience in the gaming industry prior to this, in part just because I'm thinking about the second question, open versus closed data. And in healthcare, a lot of people appropriately are concerned about the privacy of their personal health information. I'm not a gamer, so forgive me if this is naive assumption, but I would think that in the gaming world landscape, there is less reticence to be open with one's personal, et cetera. And I'm just wondering if there's any lessons learned from those experiences and how we can open rather than fear that Big Brother's watching.
Yeah, it's a good question. So I'll give you like a really specific example of what we learned in gaming and how we're applying that now to what we're doing. So when we were making iPhone games, really among the first social connected iPhone games at the start of the iPhone platform, we would do what was typical at the time, where you would download the app, and the first thing that would happen is we would put a sort of registration wall in front of the game experience. And even then, in, I would argue, a category where, generally speaking, privacy concerns are less, and the demographics tend to be younger, and inherently younger demographics tend to have less privacy concerns. Even with all those things being true, when we put that registration wall up in front of a game on our platform, we would see 30% of the user base churn out immediately. So when we started the company, the idea that, like, if it's that high in that situation, imagine if you're building an app where you're helping people manage their personal data every day in regards to their medications and their therapies and their conditions. We thought we'd see an even higher churn rate. So we do something very unusual. We don't even require registration to start using our app. We let people do it on their own, and we create a randomly generated identifier to save state for them on the servers and things like that. But we let people register on their own time. And what we find is actually a remarkably high number of people do. Some right away, most later, as they begin to really value the app, build a history in the app, accumulate points in the app, and things like that. But we want them to do that on their own terms. And that's just fundamentally a philosophy that we've brought. And it's largely based in gaming. I think in these cases, the issues are much more of concern, I think, to most people, even than in gaming.
I think there's another piece too, that everything people are, and we're inherently wired to do like cost-benefit analyses, I think. And so right now, people don't see very much benefit from me having my data in a place. And when that benefit starts to increase, the cost starts to seem a lot lower. And I think we'll start to see this debate morph very greatly, because right now all you do is read about bad things that happen, but I'm not gaining any personal benefit from my data being out there. And that just will change, and I think it's fundamentally going to change. I think it's overblown a little bit, to be honest.
Obviously, for each individual, it's going to be a different time course. Some people already have their data out there.
Sure.
So when do you see this take place?
That I don't know.
No crystal ball you can predict for?
But actually, Chris's point is well taken. We hear in the news over and over of breaches and privacy. We haven't heard of, there haven't been many stories of data doing good, actually. Have there? Jonathan, have you heard any?
Well,
or mainstream New York Times, Wall Street
yeah, I mean,
Journal?
there actually is a lot in our community, in the cancer community. So if any of you saw the Angelina Jolie op-ed from last year in the New York Times.
That's
she had
okay, that's true.
Well, I mean, that is a very nice case of patients forming an activated community, putting their data out there, not everything, not as much as we need, the community needs and that they should, but they put out information about how to interpret the BRCA1 and BRCA2 gene, and that's actually informing people's healthcare today. And you'll hear a talk later from a BRCA advocate who's speaking, I think, at 1:30 on the main stage about her personal journey with this. But it actually is impacting clinical decisions. It is impacting patient care. Now, part of the challenge is convincing people that they should be sharing more information so we can empower this community even more than we are today. But with the limited effort and limited tools available right now, we are making a difference.